statins are effective in primary and secondary prevention of CVD. Now, if you have to choose, primary prevention is usually considered optimal, but there's really no consensus on how to best identify people at risk for CVD, when to commence screening and risk assessment, and at what age to start or stop treatment. So a variety of questions need to be answered, and there is an interesting study coming out in the December 22nd issue of JACC. It's primary prevention with statins, trial-based and hybrid approaches compared with the 2013 ACC-AHA risk assessment and cholesterol treatment guidelines. And I am with one of the authors of that, Dr. Børge Nordestgaard, who is a clinical professor at Copenhagen University Hospital in Denmark. There was a lot of controversies when the new ACC-AHA guidelines first came out in 2013. They published in 2014. Why did you do this study, first off?
Well, I mean, of course, as a European, I have also followed all this discussion about the American guideline. Was it good or bad, and so forth. And then these interesting suggestions to do it in another way, actually just going directly for what has been shown in randomized interventional trials. So the American College of Cardiology, the American Heart Association guidelines, they really try to use evidence-based medicines and then based on that find who should get the most benefit. But then other people say that we should only do as the people that come into these trials. So we compared these two suggestions head to head in a big Copenhagen study called the Copenhagen General Population Study. And we found, I think somewhat surprisingly, that the American ACC-AHA guidelines, they got it right. They got it much better than actually going directly for who was recruited into the trials.
What exactly did you find? It was a head-to-head comparison, right?
That's right.
Describe the hybrid approach, which is what you talk about in here. You've got the trial-based and a hybrid approach, just so that we're all on the same page.
Yes, I can tell me. So overall, we have about 38,000 people from Copenhagen. They were without atherosclerotic cardiovascular disease at baseline, diabetes, and they didn't get a statin. So those are the ones you would evaluate for primary prevention, should they have a statin or not.
Right.
And then we took the exact criteria from the ACC-AHA guidelines and looked at all these people that were in there and how many would have a statin, and it was about 42%. And then if we took in the same cohort of 38,000 people, those that would come into one of the 5 primary prevention trials that were used, then would be 56% that would get statin treatment. But then there's this hybrid approach where you have to sort of like do both. You both have to apply to the high-risk strategy of the ACC-AHA guideline and be eligible in one of these trials, so you're completely sure. And then it would be a much smaller proportion that would get statin, I think only about 20-some%.
I mean, that was one of the concerns of and criticisms of the original guidelines when they came out in 2013 of potential over-treatment. And there are these concerns that still persist, that if you use the ACC guidelines, there's going to be too much, there's going to be over-treatment. So you did not find that, though?
No, not at all. Actually, what we did was, then we looked at the ones that during up to 5 years, actually all the way up to 10 years of follow-up, who actually got an infarction or got some other cardiovascular events, and ASCVD events. And among those that did get an event, the ACC-AHA guidelines were by far the best at finding right ones giving statins. So when you compared with a so-called, it's called NETH reclassification index, where you try to see how well you are at it, then the guidelines were much better at getting the right people a statin than the trial-based approach or the hybrid approach.
Now, we probably should say that all 3 approaches kind of suffer from limited data regarding non-Caucasian individuals, correct?
Yeah.
And so that certainly continues to be an issue. But do the results kind of resolve this dilemma for the practicing clinician in terms of who to treat and how to treat?
I mean, I certainly think that if you should compare these 3 approaches, the practicing physicians are much better off just sticking to the guidelines because they are much better at identifying the right people who would get benefit from getting a statin.
Now, they're not going to throw you out of the ASC for saying that, are they?
No, fortunately, I'm not a member of the ASC or the ASA. I'm a European. This is a continent way on the other side of the Atlantic, so I'll just go there. And Denmark consists of all these small islands, so if somebody go after us, we just go out to a small island and hide there.
The results indicate that the ACC-AHA guidelines will prevent more ASCVD events than trial-based and hybrid approaches, and at least compared with the trial-based approach, it will achieve that by treating fewer patients. Is that correct?
That's right, yeah.
So you were saying it was a little surprising.
Yeah, I mean,
where did you think it was going to fall? Trial-based?
No idea. That's not how I do research. ask a good question and have a lot of data to really show what is right and what is wrong, and then whatever result come up, I'll stand to that, and that's it.
I think it's going to be surprising to some people.
Oh, I'm sure. But that's what good science is about. I mean, if you can show some with solid data and some people are surprised, that's fine. I have no problem with that at all.
Well, I think this was great, and I really appreciate the time that you've spent with us and the fact that you've got this paper. It's in the December 22nd issue of JACC, by the way, so please check for that. And Dr. Bittner has an editorial comment that goes along with that. For Cardiosource World News, I'm Executive Editor Rick McGuire.